Hello, my name is Roger Henderson. I'm a GP and I also co-host the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. Now, one of our GP listeners has got in touch with us recently to ask whether we would look at covering paraesthesia, and we thought that was an excellent idea. So just to remind us about paraesthesia, this is usually defined as an abnormal sensation perceived on the skin or mucous membranes, but without any external stimulus. And these sensations are often described by our patients as tingling, pricking, pins and needles, burning, crawling, buzzing, or even a subtle form of numbness, and their experience is highly subjective. And although typically non-painful, they can be highly distressing. Now, while transient paraesthesia is a common physiological occurrence resulting from temporary nerve compression or ischemia, such as what we've all experienced when a limb falls asleep, usually after sitting or sleeping on it, persistent or recurrent paraesthesia may indicate an underlying neurological, metabolic, or systemic disorder that does require diagnostic evaluation and intervention. Now, as GPs, we often approach paraesthesia by categorizing it based on temporal patterns. So, transient paraesthesia, being episodic and self-limiting, frequently results from acute mechanical disruption of nerve conduction. So simple postural nerve compression, such as prolonged leaning on the elbow to affect the ulnar nerve, can lead to localized paraesthesia that then resolves quite promptly upon alleviating the pressure. Chronic paraesthesia, by contrast, suggests a more sustained or progressive process affecting neural function, and this form can present insidiously, sometimes waxing and waning in character, and may point towards problems such as peripheral neuropathies, spinal cord pathology, and even central nervous system demyelination. Now, I think it's probably worth very quickly mentioning the pathophysiological mechanisms underlying paraesthesia, which involve disruptions in the normal activity of sensory neurons along the somatosensory pathways. So, at a cellular level, aberrant neuronal firing often stems from either demyelination of nerve fibers or axonal degeneration. Myelin loss, particularly of large diameter fibers, impairs conduction and exposes the axonal membranes to irregular depolarization, whilst axonal damage disrupts the integrity of signal transmission from the periphery to the central nervous system. In many peripheral neuropathies, particularly those of a metabolic or toxic cause, oxidative stress and impaired mitochondrial energy production compromise axonal health, which then leads to degeneration and eventually sensory loss. The nervous system pathways involved in the perception of paraesthesia may be peripheral, spinal, or central. When the peripheral nerves are involved, patients may report a distal symmetric pattern, such as we see in diabetic peripheral neuropathy. And in these cases, small, unmyelinated C fibers and thinly myelinated A delta fibers are frequently affected, resulting in sensations that typically begin in the toes and fingers before then progressing proximally. Entrapment neuropathies represent another peripheral cause, with specific nerves compressed at anatomical sites, leading to localized sensory abnormalities. And a good example here would be carpal tunnel syndrome, involving the median nerve of the wrist, which classically produces paraesthesia in the palmar aspects of the thumb, index, middle, and lateral half of the ring finger, often exacerbated at night or with repetitive wrist motion. Central nervous system involvement is commonly seen in demyelinating disorders such as multiple sclerosis, and in these cases, paresthesia may result from lesions affecting the dorsal columns, spinothalamic tract, or thalamus, and these disrupt the relay of sensory input to the brain and can present in any region of the body depending on the location of the demyelinating plaque. Paresthesia due to central lesions may be associated with other neurological signs, including things like weakness, visual changes, or spasticity. And similarly, cerebrovascular accidents can cause a contralateral paresthesia, often accompanied by motor deficits or higher cortical dysfunctions. Now, if we're looking at chronic paresthesia, diabetes is really one of the main culprits here, as in long-standing, poorly controlled diabetes, hyperglycemia leads to microvascular injury, non-enzymatic glycation of proteins, and the accumulation of sorbitol within nerves, all of which culminate in peripheral nerve damage. And the resulting neuropathy is predominantly distal, symmetrical, and sensory predominant in its early stages. As we know, patients commonly describe burning, tingling, or numb sensations in their feet and hands, which may be worse at night and are often associated with reduced proprioception, vibration sense, and impaired balance. Now, we can also sometimes forget that nutritional deficiencies are a crucial but often under-recognized cause of paresthesia. So vitamin B12 deficiency, for instance, may present initially with very subtle sensory disturbances, especially in the distal extremities, and progress to subacute combined degeneration of the spinal cord involving the posterior columns and corticospinal tracts. This condition may lead to proprioceptive loss, spasticity, and ataxia if not properly corrected. Pyridoxine toxicity or deficiency can similarly lead to sensory neuropathy, with high doses from supplements being a common iatrogenic cause. Thiamine deficiency, particularly in individuals with chronic alcohol use, may also trigger a distal paresthesia and limb weakness. Now, endocrinopathies such as hypothyroidism can all contribute to paresthesia through a combination of slowed metabolic activity, mucopolysaccharide deposition around peripheral nerves, and increased risk for entrapment neuropathies. Electrolyte imbalances, notably hypocalcemia and hypomagnesemia, can all lead to neuromuscular hyperexcitability that manifests as perioral tingling, muscle cramps, and carpopedal spasms. And these symptoms often present acutely and may be accompanied by a positive Kvostek or Trousseau sign in more severe cases. Now, toxins and pharmacological agents also play a substantial role in the development of paresthesia. So chemotherapeutic agents such as vincristine and cisplatin are among the most neurotoxic, with many patients developing a cumulative dose-dependent distal axonal neuropathy. Heavy metals like lead, arsenic and mercury exert a direct neurotoxicity, often affecting both motor and sensory nerves. Chronic alcohol consumption not only predisposes individuals to vitamin deficiencies, but can also directly injure nerves through poorly understood toxic mechanisms. Infectious and immune-mediated neuropathies can also manifest with paresthesia. So, Guillain-Barré syndrome frequently presents with paresthesia in the lower limbs, often accompanied by ascending motor weakness and areflexia. In chronic inflammatory demyelinating polyradiculonopathy, paresthesia may be a predominant feature and may progress insidiously. And infections such as HIV may lead to a distal symmetric polyneuropathy either as a result of the virus itself or as a side effect of antiretroviral therapy. Now, finally, when talking about possible causes here, I think it's very important not to overlook functional or psychogenic causes of paresthesia. Patients with significant anxiety disorders, depression, or somatoform disorders may report extensive paresthetic symptoms that defy neuroanatomical logic. Now, while these cases often lack any objective neurological deficit on examination, in my experience, the subjective symptomatology can be so profound that any such presentations should be approached with empathy and a careful balance between a medical evaluation and psychological support. So if we're looking at diagnosis here, the approach to a patient presenting with paresthesia requires a thorough history and physical examination. GP should inquire about the duration, distribution, and character of the symptoms, any associated motor or autonomic features, any comorbid conditions, medication use, occupational exposures, alcohol consumption, and nutritional status. Our neurological examination should assess for light touch, pinprick, temperature, vibration sense and proprioception, as well as reflexes, motor strength, coordination, and gait. Any laboratory investigations that we do should be tailored to the suspected etiology. Routine blood work might include a complete blood count, a fasting glucose and HbA1c, thyroid function tests, renal and liver tests, vitamin B12, folate, vitamin D, calcium, magnesium, and systemic inflammation markers. In patients with suspected autoimmune involvement, then testing for antinuclear antibodies, rheumatoid factor, and specific autoantibodies may be warranted. With investigations, electrophysiological studies are often essential in confirming a diagnosis and characterizing the type of neuropathy. Nerve conduction studies can distinguish between demyelinating and axonal processes, while electromyography can assess for denervation or myopathic changes. Magnetic resonance imaging of the brain or spine may be necessary if central causes are suspected, such as MS or spinal cord compression, and inflammatory neuropathies may require CSF analysis, which can reveal albumin cytological dissociation in Guillain-Barré syndrome or inflammatory markers in infectious or neoplastic causes. Now, the treatment of paresthesias is fundamentally a very simple one because it depends on addressing the underlying cause, but as we all know, this is much easier said than done. For a diabetic neuropathy, strict glycemic control is the key here, although symptomatic relief may require medications such as gabapentin, pregabalin, duloxetine, or even tricyclics. In cases of vitamin deficiency, replacement therapy can fortunately lead to rapid and often complete resolution of symptoms if given early. Entrapment neuropathies may respond to conservative measures such as splinting and physical therapy, though surgical decompression may be indicated in severe or refractory cases. Autoimmune neuropathies may require corticosteroids, intravenous immunoglobulins, or plasma exchange, depending on the severity and chronicity of the disease. If a patient has a chemotherapy-induced neuropathy, then dose adjustment of the offending drug may be necessary, and functional paresthesias should be managed with a combination of reassurance, psychological therapy, and the treatment of any underlying psychiatric disorder. Symptom control in patients with chronic irreversible neuropathies usually requires a multimodal approach, combining medications for neuropathic pain, physical rehabilitation, occupational therapy, and psychological support. and some patients may benefit from alternative therapies such as acupuncture or TENS, although the evidence for the effectiveness of these does remain rather mixed. So just to pull this broad topic together, I think that paresthesia represents a complex clinical symptom with a broad and intricate differential diagnosis that may be benign and completely self-limiting, or it may herald the onset of a serious neurological or systemic disease. So our task as GPs is to try to interpret the patient's symptoms, correlate these with anatomical and physiological principles, and use a diagnostic pathway that involves laboratory, electrophysiological, and imaging options. Effective treatment requires not only resolution of the underlying pathology, but also sympathetic management of the patient's symptoms, functional limitations, and psychological well-being. Now, if we can do this, I really do think we can transform paresthesia from a frustrating symptom into a meaningful diagnosis and ultimately successful treatment. So I do hope you found that this quick overview of paresthesia was helpful, but have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts, as in this case. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.